Thanks for tuning in. This is David Hardy. I'm a vascular surgeon at the Cleveland Clinic, and I am going to talk today about abdominal aortic aneurysm. I have no disclosures. The aortic aneurysm was discussed by Sir William Osler, one of our fathers, and he stated there's no disease more conducive to clinical humility than aneurysm of the aorta. And I think that still reigns true today as we are trying to figure out how to manage this disease from the aorta or from the heart down to the iliac vessels. To start off talking about this, I'm going to define aneurysm and what is the definition of an aneurysm. Well, before we get to aneurysm, there's arteriomegaly, and that's just a term it means diffuse enlargement of an artery. Ectasia is the next level. That is what we call a dilated artery that hasn't quite reached the size to be an aneurysm. So is diffuse dilation of an artery with a diameter that is less than 150% greater than normal. So for an example, what we're discussing today, the infrarenal aortic abdominal aorta should be on average about 2 centimeters. And at 150% size, that would be 3 centimeters. So anything between 2.5 and 2.9 centimeters, we describe that as ectatic or having ectasia. The aneurysm is once you get over that 150% greater than normal size, or 1.5 times normal. So at a 2 centimeter average aorta, aneurysm would be defined as a 3 centimeter or greater diameter of the infrarenal abdominal aorta. The infrarenal AAA is in fact the most common aneurysm, and we'll repeat that throughout. And then finally, a false aneurysm or a pseudoaneurysm is a dilation of the blood vessel that is not a full thickness. So arteriomegaly, ectasia, and aneurysm all include all levels or all layers of the blood vessel wall, the intima, the media, and the adventitia. But a false aneurysm is lacking one of those, so it does not include all layers of the vessel. For centuries, we have known about aortic disease, and it has been a problem. So even hieroglyphic texts from Egypt attest to the presence of aneurysms millennia before the birth of Christ. In fact, we think we're pretty bright at performing all these endovascular advanced techniques and wiring aneurysms. There's some documentation of aortic aneurysms being wired as far back as some of these Egyptian hieroglyphs. And there are some pictures here that have been taken from mummies that have had their aortic aneurysm with wires put in them. And there have been reports of wiring these, but they didn't turn out so well as these became infected or occluded, and these patients typically died very quickly. But if we think about it today, it's probably been thought about in the past. The epidemiology, the most common location is the abdominal aorta. This represents, infrarenal abdominal aorta represents about 30% of aortic aneurysms, because aneurysms can occur anywhere in the aorta from the root at the heart all the way down to the iliac vessels. And in autopsy studies, the frequency rate of abdominal aortic aneurysms has been reported to be 0.5% up to 3.2% of patients or cadavers in autopsy studies. And in our large United States VA screening study, the prevalence in a VA system and these patients being screened is up to about 1.4%. White men have the highest incidence of AAA. So typically white men have about 3.5 times the risk of having an aneurysm than African Americans, Asians, or persons of Hispanic heritage. And then when we define an infrarenal abdominal or an abdominal aortic aneurysm, we define it in relation to our renal and visceral vessels. So a suprarenal aneurysm is an aneurysm where that involves the origin of one or more of the visceral vessels, but does not include the chest, the thoracic aorta. A pararenal aneurysm is an aneurysm that arises from the renal arteries arise from the aneurysmal segment of the aorta, but the aorta at the level of that, or at the level of the mesenteric vessels, is not aneurysmal. I have pictures of this in a moment. And a juxtarenal aneurysm is an aneurysm that originates just beyond the renal arteries. It's typically within 1 centimeter of the renal arteries, whereas an infrarenal aneurysm originates below the kidneys or the renal arteries, and it's usually greater than 1 centimeter away from the renal arteries. And here's a diagram to kind of show what I just said. The suprarenal is above the renal vessels, the aneurysmal segment, but does not go into the chest. The pararenal includes the renal vessels, but does not include the mesenteric vessels. A juxtarenal does not include the renal arteries, and it's usually within about 1 centimeter of the renal arteries, and the infrarenal is typically greater than 1 centimeter away from the renal vessels. AAA mortality reported in the United States in 2010. It was the 13th leading cause of death in the United States. However, mortality rate has decreased over the past 20 years by about half. We think that's due to our advanced or kind of more aggressive screening of abdominal aortic aneurysms, and I'll discuss that in a little more detail later on. But the Medicare Society of Vascular Surgery, our SAVE Act, will discuss there are patients that once you hit 60, 65 and you're enrolling into Medicare, you get a one-time ultrasound of your aorta. And we think some of these things have decreased the mortality over the years. That and our advanced techniques and being able to perform endovascular repair for rupture. The first one was performed in '94, and the more and more we're able to do these and get better at these, we think our mortality has decreased over time. People over 60 years old, aortic aneurysms are found in about 8% of these patients. Specifically in men, we find in men over 65, it affects about 15% of them. And the average age in a patient with an aortic aneurysm is 75 years old. It is a male-dominant disease or predominant disease, and affecting males to females about 6-to-1 ratio. And the elective repair prior to symptom development is the most effective means to prevent rupture and death. The prevalence of aortic aneurysms, and when you were looking at patients who have an abdominal aortic aneurysm specifically, and it's over 4 centimeters, you see that in about 1% of men, 55 to 64 years old. The prevalence increases about 2 to 4% per decade. 99% of these, as we discussed, are male, or the majority are male, and the majority of these patients were white. AAAs occur with greater frequency in men. Again, that's the common theme. Smokers and patients with a family history of abdominal aortic aneurysms, or with a family history of aneurysms in general. When someone is diagnosed with an abdominal aortic aneurysm, there are associated aneurysms that we look for typically. These aneurysms can be juxtarenal or suprarenal, like we just discussed, and include a bit more of the aorta. That's about 5 to 15% of patients with the abdominal aortic aneurysm. 10 to 25% of patients with a AAA, 10 to 25% will have involvement of their iliac arteries. 12% of patients with a AAA will have synchronous thoracic aortic aneurysms, and about 14% of patients with an abdominal aortic aneurysm diagnosis will have a femoral or popliteal aneurysm. So these, in patients who show up to your clinic who have an abdominal aortic aneurysm, one of the first things you can do is perform an ultrasound or a physical exam of the femoral and popliteal arteries to try and rule out an aneurysm, maybe followed by another imaging study. Conversely, if you have a patient with a popliteal aneurysm that's been diagnosed, one of the first things you need to do is diagnose or ultrasound their belly or scan their belly to see if they have a AAA. Because if you have a popliteal artery aneurysm, 62% of those patients will have an abdominal aortic aneurysm, and if you have a femoral artery aneurysm, about 85% of those patients will have an abdominal aortic aneurysm. So very high association there. The pathogenesis of a AAA It's typically a degenerative process. I mean, this can be atherosclerosis. It can be due to other factors, but the majority are degenerative process of the media, the muscular portion of the aorta. Typically, it's due to decrease in elastin or collagen in the wall. This could be due to the elastin being fragmented. There can be an elastic or an increase in the elastase or collagenase enzymes, and that that causes elongation and dilatation of the artery, leading to that aneurysmal formation. The cause remains unclear. I think we all agree that it's multifactorial. This is the main cause is atherosclerosis. There could be cystic medial necrosis, dissection, connective tissue disorders like Ehlers-Danlos, Loeys-Dietz, Marfan syndrome, or familial associated problems. Syphilis is an old kind of a historical cause for this, but maybe we see it in other countries still. But we have such good treatment for syphilis these days, we don't really see this as the major cause of aneurysm formation. Risk factors, smoking is by far the most significant risk factor that could lead to aortic aneurysms, along with a host of other things. Patients with AAAs, about 40% of them will have a history of hernia or may have a hernia, and vice versa. Advancing age, if we all lived to be 200, we would all have an aneurysm. Our aortas just aren't meant to last that long, and they wear out over time, enlarging over time. Atherosclerosis, hypercholesterolemia. But there are a couple of protective factors that may not be obvious, and test questions are written on this because it is an interesting fact. But patients with diabetes or patients who have diabetes, that it tends to be a protective factor against aneurysm formation and growth, oddly enough. And female gender tends to be a protective factor. As you can see, males are the most common gender with aneurysms. However, if you are a female with an aneurysm, you are more likely to rupture at smaller sizes, and we'll talk about that. So typically females are treated at smaller sizes than males. The natural history of aneurysm formation is growth. Basically, once you have an aneurysm, the aneurysm typically grows, and if left unchecked or unevaluated, eventual rupture may occur. The progressive expansion of an aneurysm is variable, and as it depends on the diameter. So as the diameter of the aneurysm grows, the rate of growth increases. The most important risk factor in following these patients is smoking or smoking cessation, because patients who currently smoke, that accelerates the growth rate by 20% and doubles the rupture risk in patients with AAA. The average growth rate and what we expect to see as we follow these patients with ultrasounds or CT scans is about a 2 to 3 millimeters a year growth rate. This is a little chart I pulled from our Rutherford, the vascular textbook, the newest edition. But typically, aneurysm diameter is an important risk factor for rupture, and that's one of the main things we look at for rupture. And if it is a fusiform aneurysm, which I'll show a picture and discuss that in a moment, but a fusiform aneurysm tends to grow very predictably. If a patient has a 5 centimeter AAA, the 5-year rupture risk is less than 2.2%. So that demonstrates probably less than 0.75% or less than that risk of rupture per year. If you look at this chart, I'll point out the diameters here is 3 to 4, 4 or 3 to 3.9, 4 to 4.9, 5, 5.9, 6 to 6.9. And our rupture risk on this side is annual rupture risk cumulative. So if you have a 3 to 3.9 centimeter aneurysm, the rupture risk is about 0.3% per year annual. When you get larger in the 4 to 5, it's 0.5 to 1.5. And as you get bigger, 5 to 6 or 5 to 5.9, it's about 1 to 11% per year. And it gets bigger. You can see it greater than 7, our risk of rupture goes up to about 30% risk of rupture per year. So pretty significant risk of rupture. A ruptured aneurysm typically starts with a small tear. Once the wall kind of meets its Once it wears out and gets so thin, you get a tear. That tear creates a severe pain. That pain can be abdominal pain. It can be back pain, flank pain. If it's abdominal, that's typically low back pain. Sometimes patients with thoracic aneurysms, we're not talking about that today, but the thoracic aneurysm can have chest pain or back pain right between the scapula and the mid back. After this tear, it could be followed by a frank rupture. The classic teaching and the classic place you see a rupture occur is posterolaterally, particularly in the left posterolateral side, because there's kind of an open space in the retroperitoneum. To the right, there's a vena cava or other organs that kind of prevent it from going off to the right and growing to the right. So we typically see it posterolateral to the left. And if that's asked on a question, that's what we usually see. All bets are off, though. It can happen anywhere. If it ruptures to the right towards the cava, it could actually be a contained rupture in that area and lead to a fistula. So you can have an aortocaval fistula that needs to be repaired in the future. And occasionally the rupture can be anterior. If there's an anterior rupture, you're rupturing into the peritoneum typically, and this is usually fatal because you don't have the retroperitoneum to tamponade your rupture. So typically these patients don't make it to the hospital. It is acutely fatal. Patients with COPD or hypertension have an increased risk of rupture, and these patients with AAAs should be managed, or their hypertension should be managed and controlled. If a patient has a rate of enlargement that's greater than that 2 to 3 centimeters per year, or 2 to 3 millimeters, 2 to 3 millimeters, and we're looking at 0.5 centimeters or 5 millimeters every 6 months, or greater than a centimeter in a year, that's someone who may be at increased risk of rupture and should be repaired earlier, regardless of the size. Survival. In patients who rupture, about 50% will die before reaching the hospital. And an additional 50% of those patients who make it to the hospital will die prior to repair. So 24% of the total population who had that rupture. So it's a pretty significant, probably 80 to 90% risk of mortality in patients who rupture. Other features in addition to diameter that are associated with increased risk of rupture, patients who have saccular aneurysm, because there's so much tension on this saccular aneurysm, you don't have the nice, smooth, fusiform aneurysm, which is a predictable growth pattern. Typically, we believe that saccular aneurysms are non-predictable growth patterns, and they're higher risk of rupture. Presence of a dissection with an aneurysm, because you're losing one of those, the intima as a part of that wall, and you may have more degeneration of the aneurysmal wall. Mural thrombus, there's so much, we think there's so much of a chemical process or something going on in that mural thrombus that tends to increase the aneurysmal growth and risk of rupture. Patients definitely with connective tissue disorders, again, Marfan, Loeys-Dietz, connective tissue disorder, or any other connective tissue disorder have increased risk of rupture. And dissection of the peripheral calcifications on patients who have those eggshell calcification, and you can see those calcific rings are broken on the aneurysm periphery. Sometimes those patients are high risk of rupture and need to be monitored very closely or repaired. Clinical presentation. A lot of these patients are found during our screening, so about 70 to 75% of them will be asymptomatic. The symptoms could be early satiety, nausea and vomiting just due to the pressure of these, if it's a large aneurysm. These patients could have abdominal pain with rapid growth, flank pain or back pain. And a third of the patients do experience abdominal or flank pain. The abrupt onset of pain is one of those patients that we worry about acute rupture or expansion of the aneurysm. So these are patients that should be fixed pretty quickly. If they're in the hospital and not ruptured, they probably should be fixed within 24 hours. But as soon as you can find an operating room to get them in to repair. Diagnosis. Sometimes you can find these patients on history and physical exam, especially if they have a family history or another connective tissue disorder and you're looking for it. On the physical exam, I have a picture here. Most of the time, we don't get patients. Actually, almost all the time, we do not get patients that are this obvious. This patient is so thin and emaciated that their aneurysm is seen quite easily on a physical exam without exam. And if you put your hand on that bump, you're going to feel pulsations. In patients who aren't quite as thin as this gentleman, a lot of times you have to really work hard to examine them and focus on their aneurysm to feel that pulsation. And if the aneurysm sac in an obese patient is less, or the aneurysm is less than 5 centimeters, you're likely not going to find that and examine them, or be able to examine them and diagnose it on exam. But if you do feel pulsatile mass in the abdomen, the next step should be ultrasound or some sort of imaging modality. Sometimes we're lucky enough on radiographs. If you have a abdominal X-ray for other reasons, you can see the calcified outline, and you may see aneurysm. But you sometimes can determine the size in about 50 to 60% of these, or get a good estimation. But you really can't rule out a AAA if you don't see it on abdominal radiograph. So. Some of our other tools we use for diagnosis is simply ultrasound. Ultrasounds are non-invasive. They establish a diagnosis quite easily. They accurately measure the infrarenal diameter, and you can actually follow these patients with ultrasound reliably. It's difficult to use ultrasound for thoracic or suprarenal aneurysms due to the rib cage. You just can't get the picture you need up into the chest. And it's difficult to establish a relationship with the renal arteries, but it is widely available, quick. There's no real risk with ultrasound, and it's very cheap. Here's a picture, or an example of a picture we have that I have placed for one of our patients with an aneurysm. You can see it measures quite reliably, and we can follow this over time. This is about a 4.7 centimeter abdominal aortic aneurysm, and you can get transverse and AP views, measurements here in a 2D plane. CT scan is a very precise measurement. I think the ultrasound is probably within a millimeter or two difference of reliability, but a CT scan is very reliable, very producible. You can image the entire aorta, so you're no longer limited by the rib cage. It takes a little bit longer to obtain because they're usually you have to schedule this through your radiology department, or if you have one in your clinic, you have to schedule these. It's more costly than an ultrasound, and it does require a contrast agent to have a very accurate picture. Sometimes you can do it without contrast and see the calcified lining of the aorta, but it's best to see with contrast. So this contrast agent can cause risk to kidneys in patients who have a low GFR or a high creatinine, and it does require radiation exposure in patients. And you can see here's an example of the coronal section of the abdominal aortic aneurysm here that splits into our iliac vessels. MRA, so it's magnetic resonance angiography, is now very widely available. It is more expensive than a CT scan. I don't personally use an MRA, and if a patient shows up to me with an MRA and I can get a CT scan, I will almost always get a CT scan to evaluate the patients. Just because that's what I'm comfortable using and evaluating. An MRA does use gadolinium for our contrast. If you use gadolinium in these MR angiograms, you have to be careful. You can't just do an MRA in place of a CTA in patients with kidney disease. If these patients have kidney disease and use gadolinium, there's a risk of nephrogenic systemic fibrosis, which is a very significant side effect of giving gadolinium to patients with renal failure or renal insufficiency. And I believe the spatial resolution is less than CT scan when you're trying to plan repair in these patients. Angiography is another used to be kind of the gold standard. However, you cannot determine aneurysms, or not, it did not used to be gold standard. It used to be one way we determined aneurysms, but you cannot determine aneurysm size on angiography because some aneurysms, actually the majority of them, will have mural thrombus. So there will be a laminar thrombus there, and it may actually be that our contrast is only going in the true lumen, which may appear to be a normal size, about 2 centimeter vessel. However, there's significant thrombus and aortic wall that's a lot larger, and you just can't determine size on a 2D angiography. Indications, however, after you have discovered that the patient may have an aneurysm and you are pre-op planning, you may want to obtain angiography for someone who may have a horseshoe kidney to see where this kidney comes off of the aorta, to plan for any type of endovascular repair, if you're even able to, or if you have to go for an open repair in these patients. Screening for abdominal aortic aneurysm, we discussed, I kind of mentioned it briefly earlier, but the United States Preventive Services Task Force, USPSTF, suggests that men who are ages 65 to 75 and who have ever smoked, should be screened one time for AAA by an ultrasound. The American College of Cardiology and American Heart Association suggests that men 60 years or older who are either siblings of offspring or who are either siblings or offspring of patients with AAAs, and or men who are 65 to 75 who have ever smoked. And Society of Vascular Surgery and Medicare suggest patients who are 65, just males 65 to 75, or with a smoking history of at least 100 cigarettes in their life, should be screened for an abdominal aortic aneurysm. And in fact, on their Medicare enrollment, most men are allowed a one-time screening ultrasound. And we believe that's probably where our mortality rate, that like 50%, has decreased over the past 20 years from AAA rupture. Most patients who have an aneurysm are asymptomatic, and we follow these patients, and hopefully we discover their AAA and can follow them over time. The natural history data on these patients who are asymptomatic help us balance the risk of rupture with that of the surgical morbidity and mortality, because there are risks of repairing these. And the rupture risk correlates directly with the size, as we've already discussed. If a patient has a AAA less than 5 centimeters, it's a very low risk of rupture. And once this AAA reaches about 5.5 centimeters, that is the threshold used for repair. We'll go over this over and over because this is typically the question in your mind when you see these patients or on testing. But a AAA of 5.5 centimeters is what the Society of Vascular Surgery used to repair in men. Greater than 5 centimeters is what we use for repair in women who are candidates to undergo endovascular open surgery. Again, predictors of rupture are going to be female gender, so that's why we choose to repair these patients at a smaller rate. Family history of AAA, abdominal pain, smoking status, high blood pressure, and COPD. So we hope to get them to stop smoking to control their blood pressure. 2 randomized trials we use that have been around for a while, but they've been performed to evaluate the role of early repair. So in patients who have small aneurysms, should we treat them? And we tried to answer that in the UK small aneurysm trial, or the aneurysm detection and management trial. That's the ATOM trial, which is a trial out of the VA system. The UK small aneurysm trial was a trial randomized. They randomized about 1,000 patients, evaluating early elective AAA repair versus surveillance. And this included patients who had a 4 centimeter to 5.4 centimeter aneurysms. The operative mortality in these patients were 5.8%, and the annual rupture rate in surveillance was not significantly elevated. It was about 1% overall, 0.3% for those under 4 centimeters, and 1.5% for those over 4 centimeters to 4.9 centimeters. The ATOM trial looked at a similar number of patients, about 1,100 patients, looking at ages 50 to 79 years old, had the similar arms, a surveillance arm and an immediate open surgical repair, and their 30-day mortality was about 2.7%. And the patients, we looked at the patients with AAAs from 4 to 5.4 centimeters. The annual aneurysm rupture rate in the surveillance population was 0.6%. And the long-term results were very similar in both groups, concluding that an elective AAA repair should be for patients who have a AAA 5.5 centimeters or greater. The treatment risks, so when you choose to treat these patients, our mortality, and it depends center to center, but the mortality is typically 0.9 to 5% with current surgical techniques. The morbidity is about 5 to 10%, usually associated with cardiac events. And the endovascular techniques that we have today and we've improved upon are significantly reducing our morbidity and mortality associated with the repair. The mortality risk, mortality after elective open surgery is about 5%. And talking about the endovascular repair, or the EVAR, it's about 1% now. And there are about 6 independent risk factors for mortality, or mortality after operative risk of operative treatment of AAA. And that's acute renal insufficiency or chronic with a creatinine of 1.8, congestive heart failure, EKG detected ischemia, pulmonary dysfunction, older age, and female gender. So typically, we talk about the treatment and the risks. Well, what are the indications for repair when you have someone with an abdominal aortic aneurysm? Like we discussed, someone who is asymptomatic and we've been following, typically someone who has a male who has a greater than equal to 5.5 centimeters aneurysm below or infrarenal abdominal aortic aneurysm, and females are greater than or equal to 5 centimeters. Patients have symptoms of thrombosis. So if the aneurysm thromboses and includes, these are patients that are typically medical emergencies and need to be repaired or evaluated very quickly. If these aneurysms are compressing adjacent organs or creating aortocaval fistulas like we talked about earlier, aortic dissection and degeneration, rapid expansion, impending rupture, frank rupture, and then some patients can present with embolization to their lower extremities. And if you can't find a source, other source, it may be an abdominal aortic aneurysm, and these patients should be repaired early or earlier and independent of their size if it's constantly causing these embolic events. You repair smaller aneurysms, as we discussed earlier, at about if they have a rate of growth greater than 5 millimeters per 6 months or greater than a centimeter in 12 months. You repair all symptomatic aneurysms, regardless of size, with abdominal pain, back pain, or tenderness over the aneurysm sac, regardless of the size. And alternatively, if a patient shows up to you and has a significant comorbidities, these are congestive heart failure, pulmonary dysfunction, or other comorbidities, we may wait until their aneurysm is larger, about 6 centimeters, because it really is about the risk of rupture and the risk of repair to have that risk-benefit relationship. And if these patients can be fixed easily with an EVAR, great. But if they are a complex thoracoabdominal endovascular repair or a fenestrator repair, these are patients that may need to wait until their aneurysm is a little bit larger before we offer them repair due to the risk-benefit ratio. Other indications for treatment is a lot of people, and I'm one of these included, if you have a saccular aneurysm. These patients tend to repair these at smaller sizes. If you have a dissection of the mural thrombus or fracture of that saccular calcification looking like an ominous sign of rupture, or patients who, again, have that emboli to the feet or other organs, those would be patients I would treat earlier. Again, just to drive this point home, elective repair, less than 5.5, there's really no survival benefit as compared to treatment in patients who have been, who we just surveil and perform an elective repair at 5.5 or greater. Secondary considerations. So once we choose to treat these patients, do we pursue open versus endovascular? This is something that only you and your patient can discuss. There are advantages and disadvantages to open or endovascular approaches. Overall, the long-term mortality is equal if once these patients reach about 2 years, but endovascular clearly offers a reduced 30-day mortality. So especially in patients with significant comorbidities, these are patients who may benefit from the endovascular repair. And where we got those numbers or those answers were our large randomized studies like the EVAR1 trial, DREAM trial, OVER trial. I put those here as a reference, but typically overall these suggest that long-term survival outcomes are equivalent, that EVAR is associated with a short-term survival advantage. Open surgery is associated with a lower reintervention rate. EVAR does require continual long-term surveillance, so that requires either ultrasounds or CT scans, which may accumulate radiation. You may accumulate exposure to contrast media, which could perform or affect your kidney function long-term. So these are things to discuss with your patient so you can come up with a treatment options is best for your patient specifically. It can be tailored to them. The standard surgical repair is typically a midline approach or a retroperitoneal, so transperitoneal or retroperitoneal incisions. There are reasons to do both. There are reasons to have both in your toolbox. Some people prefer one over the other for one reason or another. But the typical, the overall is replacing the diseased aorta with an artificial artery. That may be aortic homograft. That may be Dacron. That may be polytetrafluoroethylene or PTFE. Typically, the average stay is about 5 to 7 days in a hospital. Recovery time is 3 to 6 months before these patients really start feeling normal again. But they're up and at them probably the first couple of weeks after surgery, just not quite back to normal. And is a proven method with good long-term results. The first repair of an abdominal aortic aneurysm was by DeBost, Dr. DeBost in 1951, and he used a preserved homograft from a 20-year-old female used as a conduit. Voorhees, Dr. Voorhees and Dr. Blakemore actually in 1952 performed our first open AAA repair with prosthetic. They had a rupture that came in, needed to be taken to the OR, and in the middle of that case, the aorta bank was empty. There was no aortic homograft. They broke scrub, or one of them broke scrub, reportedly, ran to the dog laboratory and sewed a synthetic bifurcated tube graft made of Vignon, which is a kind of form of polyvinyl chloride. And this was the first prosthetic bypass that was performed. The cross clamp of the aorta was 3 hours, and when removed, it was reported that the patient bled from everywhere except the prosthetic graft. So this was the very first prosthetic aortic bypass in a rupture. How do you choose? We talked about two different approaches, the transabdominal and the retroperitoneal approach. So there are some reasons to do one over the other. Patients who've had prior retroperitoneal surgery may be better served with the transabdominal. Patients who have a ruptured AAA and it's localized to the infrarenal segment, transabdominal may be great. Exposure for that. Exposure of mid to distal visceral vessels can be performed with a transabdominal. I think it's just easier to do a retroperitoneal on those. If you have to get to the right internal or external iliac artery, it can be very difficult from a retroperitoneal exposure. So I think a transabdominal may offer some advantage here. If patients have coexistent abdominal pathology, then a transabdominal approach may actually be the way to go, especially if someone had an aortocaval fistula that had to be repaired. And if a patient had a left-sided vena cava, that actually may prove to be difficult through retroperitoneal exposure. Retroperitoneal would be the way to go if a patient had prior midline abdominal incisions. You can stay out of that scar, but that's not a definite. You don't have to do that. Patient has a abdominal wall stoma or colostomy bag. A retroperitoneal may be the better option. An inflammatory aneurysm. So these are like porcelain aneurysms. It'd be very difficult to tease off the duodenum or surrounding structures on this inflammatory aneurysm. So it's best to approach this from the side, so you do not have to, or in theory should not have to peel off the these structures that you're almost certainly going to injure trying to operate around an inflammatory aneurysm. If you did transabdominal, obese patients are a little easier retroperitoneal, and typically there's fewer GI complications since you stay out of the GI or the peritoneum. Preoperative assessment and planning. So selecting the approach, we talked about the transperitoneal being ideal for infrarenal or juxtarenal. You can also perform a medial visceral rotation on this for supraceliac clamping, but the retroperitoneal, I think, is better in anyone you think you may end up going supraceliac on. Now, if we do select a transperitoneal approach and you need to get higher to have a clamp position above, or a clamp position, but the renal vein is in your way, you have to make this determination as you're exposing. You can either take these lumbar branches from the renal vein or the gonadal vein, but you can't take those and transect the renal vein as you see here. If you plan to transect the renal vein, you should leave these collateral venous vessels in place so the kidney has a place to drain. This is a common question on your boards potentially, but where do you ligate and transect this renal vein if it is in your way for sewing? You can actually you take it. If you do not take the gonadal vessels or the lumbar vessels, you are to ligate the renal vein as close as possible to the vena cava, and that gives us that leaves those collaterals in place so that your kidney has venous runoff. If you plan that you can mobilize this renal vein without having to transect it from the vena cava, then you can ligate these the gonadals and lumbar vessels in order to mobilize this up and give yourself enough space to clamp and sew. If you do have to if you're in a transperitoneal position and you have to get higher than that renal artery and you're having to get into the mesenteric segment, you may actually have to perform a medial visceral rotation, which is a Maddox maneuver. Mobilize the white line of Tolt, mobilize your colon, and mobilize your medial visceral or your visceral structures, exposing the abdominal aorta. And we've all done this in trauma situations, so it would be no different, but hopefully a little more controlled than in a trauma situation. Typically a midline approach in the transperitoneal. Opening the abdomen, the colon is taken cephalad, the colon omentum, the small bowel is retracted to the right, and the peritoneum is opened, exposing your aorta. And once your aorta is exposed, clamping, creating a midline incision, cleaning out any mural thrombus, ligating these lumbar vessels with a suture, usually like a Ticron suture, or some non-absorbable suture, and performing your anastomosis and performing your anastomosis in the aorta, and either a tube graft or a bifurcated graft is used, and it all depends on the anatomy. The aortic sac, if you can, is closed over the graft, and the peritoneum is closed over as well. This will prevent, hopefully, the duodenum from fistulizing to the aorta and creating aorta-enteric fistula in the future. For the retroperitoneal incision, you kind of choose your approach based on how high you have to clamp. Typically, a 9 or a 10th interspace can get you as high as you need to be from a infrarenal, pararenal, or suprarenal approach, and even a type 4 thoracoabdominal approach as well. Typically, once you open this thoraco-retroperitoneal incision, you have to make a decision about where the renal artery or renal vein lies, and then you make that decision whether you elevate your renal vessels, whether you leave the kidney down. Majority of the time, we elevate the renal vessels, and if we have to reimplant it, we do, as you can see here, with either a bypass or potentially sometimes can be directly reimplanted into our bypass. This is an example of a thoraco-retroperitoneal, but this is more of a type 3 thoracoabdominal aneurysm, and sewing our graft into the aorta proximally. These are bypasses to our mesenteric vessels and our distal aorta, there's our anastomosis. And interesting enough, this was a rupture, and we didn't have time to evaluate this. This patient had a left-sided vena cava, or a duplicated left-sided vena cava. Concomitant pathology, you have to treat. This is a very common favorite question in oral boards or on tests, but you treat the most life-threatening problem first. So if the patient has a 5.5 centimeter aneurysm and colon cancer, the colon cancer is what's most threatening in this patient's life and needs to be treated first. If the patient comes in with a ruptured AAA and you find colon cancer, then the AAA is going to need to be treated first, obviously, and manage the colon cancer at a different time. Typically avoid simultaneous operations due to the increased risk of complications, and GI procedures should not occur at the same time as an open repair unless you absolutely have to in certain situations. And at that point, I would use an aortic homograft or something that would hopefully prevent future infection. If you are performing the surgery open and you find metastatic disease or abscesses are encountered, the surgery probably should be aborted, and you have to go on those on an individual basis. Management of the inferior mesenteric artery. So this is pretty common. We see the inferior mesenteric artery on the open surgery. On an endovascular procedure, you're going to cover that most of the time, and these patients are going to have, hopefully, collateral flow to that vessel. But this is something we should note on pre-op CT scan to see if this vessel is large, the inferior mesenteric, and see how the patency of the vessel. If it's thrombosed, and it was thrombosed in the pre-op CT scan, there's no need to even think about this any further. You just do your bypass. If the patient has a patent large IMA, I typically reimplant this. If you open this IMA and there is a great deal of back bleeding, you do not need to reimplant because this patient has enough collaterals to feed the colon. However, if you open the vessel, it is not occluded. It was not occluded on pre-op CT scan, but there is no back bleeding. That tells you that maybe most of the colon is coming from the IMA. This is someone you definitely should reimplant their IMA. In patients who have bilateral hypogastric artery occlusions, reimplant. And a prior colectomy, especially a right colectomy or a transverse colectomy, you don't really know what collateral vessels the prior surgeon took, and this would be someone I would reimplant the IMA. And I generally reimplant the IMA on most patients, especially being in an academic center. This is a way that our trainees can reimplant this vessel as well, and there's no harm in doing so. Venous abnormalities, so just like I showed you that left-sided vena cava on that picture, about 1 to 10% of the patients population have a venous abnormality. They may be a retroaortic or a circumaortic left renal vein that you have to know. It's very important to know where the left renal vein is, because if you're doing an open surgery and you clamp the aorta and not paying attention in that renal vein posteriorly, you can transect that vein, and that is very difficult to repair, and that would really increase your mortality of the surgery. Left-sided vena cava, there are duplicated vena cavas, there are accessory left renal veins, and then there are pre-aortic confluences of iliac veins, which can make an open surgery very difficult. So our pre-op CT scan for planning is very important for that. Follow-up after open surgery. These patients are followed closely after discharge until they're free from procedure-related complications. The Society of Vascular Surgery guidelines suggest surveillance imaging every 5 years. This should be done more often if there are clinical reason for concern. Personally, I perform a CT scan at 1 year and 5 years after an open abdominal aortic aneurysm, and I get ABIs or pulse volume recordings in the lower extremities to see if there's any change over that time of follow-up. Endovascular repair was introduced to the world in 1991 by Dr. Perotti, Dr. Palmaz, and Dr. Barone. This was the first time reported in endovascular placement in a human. By 2005, the incidence of EVAR, or endovascular repair had actually exceeded open repair. And I think today about 70% of all AAAs are repaired endovascular in the United States. Typically, this is done through incisions in the groin. At least historically, now we can do this through puncture sites, and we have devices that can close the skin, the aortic, the arterial incisions percutaneously, so we don't have to make that cut anymore. It typically requires both surgical and radiologic assistance, or as a vascular surgeon, we are able to perform the endovascular procedure or open procedure and figure out which one is the best option for our patients, because hopefully we can do both equally. And then you get significantly reduced morbidity and mortality early period. However, the long-term results of this is unknown, as it's only been around since 1991 and really in the mainstream some 10 years after that. The hospital day is typically 1 day, and the recovery time is variable. In patients who've had endovascular repair. Here's a image of an aorta. You can make out the aneurysm. This is the left renal artery and the right renal artery with the collapsed endovascular device in place. This is after the endovascular device has been placed. You can see there's metal objects above the renal vessels. These are open or uncovered stents, so this is not impeding the flow to the kidney vessels. And then you can see the exclusion of the aortic aneurysm. So this patient does not have flow into that aneurysm sac any longer. This is typically, I talked about percutaneous treatment with some of our devices. This is typically the incisions we make on a patient who undergoes abdominal aortic aneurysm repair in an endovascular age. And this is purple on here is just skin glue that has repaired these endovascular percutaneous sites. The limitations, however, not every patient needs or fits endovascular repair criteria. There are a lot of people, I think, that could try and push patients to fit the graft anatomy, but I really think your graft should actually fit the patient's anatomy, and typically you should not go outside of FDA guidelines for placement of these endovascular grafts. Patients with a short neck, less than a centimeter, potentially need open surgery or more advanced fenestrated endografting. Patients with extensive thrombus, more than about a 25% thrombus burden at the neck. These patients don't tend to do well and degenerate more. And I think open surgery are, again, more advanced techniques for endovascular therapy. Severe angulation. This is becoming less of a problem as there are grafts being developed for more severe angulation. They're currently being tested. But patients typically with severe angulation will have more migration and complications. Conical necks, so these are cone-shaped necks, and with a seal zone that is widening rapidly. Here, these patients typically tend to have endoleaks over time, and they require more interventions over time. And then patients, you have to have an ability to get the graft up into your aneurysm. And if you have stenosed iliac vessels, this may present a problem. Not always, but these are things you have to think about. So indications for an open repair would be a hostile neck, neck less than 1 centimeter, or you have to think about more endovascular advanced options, significant angulation of the neck greater than 60 degrees, suprarenal aneurysm, or you have a fenestrated endograft that typically is in an investigational device, or a young patient. Because if these patients are young and we really don't know our 30 and 40-year outcomes on these endovascular repairs, these patients young patients, healthy patients may do better with an open repair in the long run. This would be a fenestrated option, and having a device that covers the renal, and here in this case the SMA, but there's a scallop out of the cover, or there's a fenestration that's opening up here, and stents are used to open up into those mesenteric or renal vessels. But doing this still able to exclude the aneurysm sac. What are the complications? We're almost done here, but the complications of endovascular would be endoleak. This is exclusive to an endovascular aortic aneurysm repair. Migration. So over time, we've learned, and the device companies have learned, that these devices can slide down or slide up, and this is migration. This loses your exclusion of the aneurysm sac, and the aneurysm could continue to grow. These limbs could occlude, whether it be open or endovascular, and thrombose decrease the blood flow to the lower extremity acutely. The neck, when you seal the neck off, that can continue to grow and cause an endo leak. Graft infection, obviously, whether it be open or endo. Pelvic ischemia, when we cover the inferior mesenteric artery, if the hypogastric arteries are inadvertently or covered on purpose, that can increase pelvic ischemia, which means you could have necrosis of your pelvic organs. The stent fatigue and fracture, if they're in there for a long time, the metal can fracture and can cause leaks or fail. These patients can have heart attacks, groin infections, erectile dysfunction, death, about 1.8 to 5% elective repair, less than 1% in an EVAR, and 50% ruptured aneurysm repair. And spinal cord ischemia, when you're covering the spinal cord or the lumbar vessels in that significant area, it's really rare, about 3%, especially if you take out both hypogastrics, but spinal cord ischemia can lead to paralysis in the lower extremities. This is a diagram depicting endoleaks. We have type 1 endoleaks, which actually are leaks around the seal zones, either proximally or distally. Type 2 endoleak is a leak backwards from either an IMA or a lumbar vessel. Type 3 typically is caused by a defect in the graft, either due to a tear in the graft or a disconnection of the components of the graft. Type 4, we don't see this as much anymore, but so with some of the old grafts where the graft material has increased porosity and you can get some leakage of the serum or some of the blood into the sac. And then type 5, I think some people believe in this, some people don't, but an increase in the diameter without really finding out where the endoleak is coming from. It's called endotension. The follow-up with an endovascular or an EVAR, the SVS guidelines recommend CT scans at 1 month and 12 months and annually thereafter. And this could be done with ultrasounds to save on aneurysm or save on radiation and contrast. If you detect an endoleak at 1 month, it prompts a 6-month CT scan. And if there's no endoleak, then expansion or sac expansion detected in the first year, then an ultrasound is adequate annually. And that ultrasound avoids the radiation. So in summary, there appears to be an early survival benefit of EVAR over open. The benefit goes away by 2 to 3 years post-op, and we really don't have long-term data on our endovascular repairs, but that stuff is surely to come in the near future. EVAR is associated with more secondary procedures, requires more follow-up and surveillance. It may actually be more costly in the long run because of the repeat procedures and the follow-up. For small aneurysms less than 5.5 centimeters, there's no survival benefit, and close surveillance is required in these patients to follow their aneurysms. Anyone who has aneurysm over 3 centimeters in the infrarenal abdominal aorta. And then that's it.